Okay, we are now back live, and we'll be vetting everybody that enters the meeting room. So Jeffrey, apologies for that, and I'll hand back over to you, Robert and Jeffrey, to kick off.
Yeah, well, thank you, Nicole, and everyone understands the problems that comes with technology that is widely shared. So.
Yes, Nick, are you able to share with us the slides? And maybe Geoffrey, you can just, where do you want us to go? Which slide number? And we can
so it's yeah, you can go to slide 6, and if you can just skip the animation, so just play the whole slide, and then we can go to the next slide and then do the same.
Okay.
So previous slide. Yes, so I was basically talking about. So I was talking about the antiviral defense that exists in nearly all human cells, and basically this antiviral defense protects human cells from infection by any viruses, including COVID. So you may ask if there's an antiviral system that protects cells from viruses, why do we still get sick from viruses? And the answer is that viruses have evolved ways to circumvent this antiviral defense. Many times the viruses are not successful, and that's why many patients who get COVID will recover without being seriously sick. Next slide. So recently, I have been doing research on CRISPR, which, if you recall, is a system of genes that helps bacteria to fight viruses. And recently, we realized that when CRISPR is delivered into human cells, the human cells respond as though they have been attacked by a virus. And as a response, the human cells make an innate immune response that includes the production of interferon, gamma, and beta. And this helps the immune system to fight off a wide variety of viruses. Next slide. Next. So recently we have begun developing the idea of basically leveraging our observations that CRISPR RNA delivery into cells triggers an antiviral response, and to use that as a means of identifying potential antiviral drugs that could be active against a wide range of viruses. Next slide. And basically the idea is that what if we had a drug that could basically trigger this intrinsic antiviral defense that exists in all human cells? So in other words, when this drug is exposed to cells, the cells would basically behave as though they were attacked by a virus, and then start producing things like interferon gamma that help the immune system to fight off the viruses very quickly. Next. And so in the past few months, we've done some research that involves mostly computational analysis that looks at how drugs activate different genes across different human cells. And then using this data, we've been able to predict some potential small molecules that could basically mimic the infection of a virus. Next slide. Next. And our idea basically is that if we were to find a drug that would basically trigger this antiviral response in any human cell, that kind of drug could be potentially active against not just one virus, but several viruses, including COVID, SARS-CoV-2. And we have shared some preliminary results that are currently under peer review. Hopefully they'll be published soon, highlighting some of the drugs that we identified. At least 2 of those drugs have been now shown to be active against SARS-CoV-2 in the lab. Next slide. So another area of our work looks at how viruses interacts with different proteins in human cells. And the idea is that some viruses interact with the same human proteins that are required by other pathogens. So for example, we have done work that shows that the malaria parasite Plasmodium falciparum targets some kinds of proteins that are also targeted by HIV-1. And what basically this means that that because you have two pathogens that target the same protein, you end up with a shared connection between those two pathogens. And this could be a possible molecular mechanism that connects two diseases. Next slide. Recently, it was shown also for SARS-CoV-2 that the virus interacts with thousands of human proteins, including human proteins that are the targets of currently approved drugs. And the idea basically is that if the virus requires a certain protein, then blocking that protein with a drug could be a way of targeting the virus. And there's a recent study done by a group in the US that basically shows that by looking at the protein interactions between the viral proteins and the human proteins, they can basically identify potential therapeutic agents that could be active against COVID-19. Next slide. So another aspect of our work, which is a bit different, but I wanted to highlight, is that currently there's nearly 200 COVID-19 vaccines that are being developed across the world. And we've started a project that basically tries to map out all of these vaccines across the world as a way of informing the public, but also to encourage collaborations across these vaccine developers. And you can visit the platform at vaccinemapper.nd.edu. And I'm looking forward to any questions and the panel discussion. Thank you.
Thank you very much, Geoffrey, for the really exciting work that you're doing and for taking the time to share some of this with us. And apologies again for that unfortunate incident. I think just helps us to realize we do have a lot of work to do. It's interesting, just earlier, we talked about mental health, and I'll leave it at that. And welcome any questions we may have from the audience. And my personal question is just very curious about that linkage that it seems a lot of malaria drugs keep coming up from Mauritius, from US. This linkage between malaria drugs and COVID. Is that being borne out by your studies to a certain degree or not really?
Yeah, so this has, it's an interesting question because also most of the malaria drugs and even other approved drugs, we don't actually understand how they work. And my PhD was actually in understanding how chloroquine works against Plasmodium. And one of the things we know about these drugs is that basically they make certain compartments of the cell to be very alkaline. So there are compartments like lysosomes, where some viruses pass through, or endosomes. And these drugs interfere with the pH of those compartments. So this could be a mechanism that makes some of these drugs to be potentially active against both malaria and other viruses. Of course, we should say that one of the challenges of developing a drug is not necessarily finding a molecule that targets the virus. It's finding a molecule that targets the virus without killing a person. And so we know what is the challenges that chloroquine is facing, because the dose you need to use chloroquine to treat malaria is much lower than the dose that you'd need to use chloroquine against any virus. So this is one of the reasons why we need very good clinical trials to validate any potential therapeutics.
Thank you, Geoffrey. I can see Dr. Moyo, you're raising your hand. Do you have a question?
Yes, thank you. Thank you, Jeffrey, for that interesting presentation. I just want to ask you, the technology around CRISPR, is that, and I know you talked at the end around vaccines, that approach, is it superior? Would it be superior to a vaccine to have that type of molecule that would trigger the release of the interferon release? Would it be superior to a vaccine approach, for example?
Yes, good question. So, yeah, so I don't think it's hard to say whether there would be any kind of superiority. I see the therapeutic and the vaccine approach as complementary. I think the interesting thing is that because the therapeutics that trigger interferon response, which is part of the immune system, are interesting in the sense that they bring up the immune system into the therapeutics. And I think that could enhance their success. Because currently, many of the antiviral drugs are designed to target a viral protein. But the problem with that approach is that there are so many viruses, and we don't know what virus will come next. If we design a molecule that targets just a specific viral protein, then we can't rely on that drug when the next pandemic comes. And I think this gives an advantage to this approach that uses small molecule therapeutics to trigger the immune response against viruses.
Thank you so much, Geoffrey, and I'll still invite you to hang around so that we can get some more questions at the end. Now I'd like to also introduce Dr. Adelowa Adeniji. He is a consultant clinical oncologist at Lakeshore Cancer Center in Lagos, Nigeria. So Dr. Adeniji is an oncologist with a background in human anatomy science, medical physics, and anesthesia. He's previously worked as a consultant radiation and clinical oncologist at the Lagos University Teaching Hospital. And is currently involved in both clinical and community-based oncology practice, as well as, of course, working in the field of clinical research. And he has a passion for teaching and training, in addition to mentoring upcoming clinicians. I'll invite you, Dr. Adeniji, to kindly share with us a little bit about the interactions of COVID-19 with cancer, and especially what should we know, what should we be aware of, and are there any solutions? Thank you.
Oh, thank you very much, Robert. I really want to appreciate the organizers of this event for having me on this platform. And today I'll be sharing with the audience on COVID-19 and cancer care. This is an important aspect of healthcare that we all need to know. Next, please. Okay, the entire world, we all know, has significantly changed since the arrival of this August visitor called COVID-19, and every aspect of life has been affected. Oncology is not left out, and because of this, a lot of things have to be adjusted. How we treat patients, how patients come in, the treatment patients get, and how we ensure that patients still get their best care, they have the best survivor, despite the challenges in attending to them. Next slide, please. Patients with comorbidities are highly vulnerable. The previous presenter, I remember Prof talked about it when he was talking about COVID-19 and the cardiac condition. So he talked about the comorbidity. But one thing that is peculiar to one of the comorbidity, which is oncology, is that the patient themselves, they are already at high risk of having mortality and morbidity, especially the risk is actually increased when other comorbidities are added. So because of that, high index of suspicion is needed to prevent death from COVID-19. And because they have to come in, the health workers have to have high index of suspicion, and at the same time, patients themselves need to know what is expected of them. Next, please. So what is the current trend? Yeah, these are figures. We have the global figures, and then we also have regional figures like what we have in different African countries. So we can see that we have up to 14 million cases all over the world and up to 613,000 deaths all over the world. And then the recoveries we have in the next place. Okay, then figures in some African countries show that South Africa, as of today, has about 381,799 cases and 5,368 deaths so far, and then followed by Egypt. You can see Nigeria also that we have many other African countries that are affected. Next, please. So what is so peculiar about oncology patients, people that have cancer? Number one, they are vulnerable to the disease. Why? Because the cancer itself tends to give them immunocompromised state. It tends to make them to have immunosuppression. And then the treatment they're taking, for example, chemotherapy, can compromise their immune system. And at the same time, even their psychological state. There are so many reasons why patients or people with cancer are vulnerable to mortality or morbidity caused by COVID-19. And then some of them don't just have cancer. They have hypertension, they have diabetes, which have been known to increase the risk of morbidity and mortality in these patients. So imagine having 3 of these comorbidities in one patient, in one person, then that individual is highly vulnerable to the mortality that comes with COVID-19. And of course, risk of immunosuppression is very high in them. Then they are also having increased psychological distress. For example, a lot of patients will ask doctors, what will happen to my treatment? I don't want to come to the hospital. They are afraid of coming in because of COVID-19 disease. They don't want to get it. And at the same time, they want to get their treatment. So how do we balance these two situations, ensuring that the patients don't have the infection, they don't give the oncology team, and at the same time, they get their care as they should, because we know cancer doesn't wait. Cancer keeps proliferating. If you stop the treatment, cancer doesn't stop. So we need to know that this is important for us to balance the scale. Then risk of missing treatment for cancer care is high because a lot of patients are running away from the hospital. They are running away from where they were using, when they were receiving their treatment before because of fear of COVID-19. Next, please. Then for oncology care, European Society of Medical Oncologists have been able to, categorize patients into 2. The patient that has completed their treatment, how do we ensure that they have their follow-up without getting COVID-19? And patients that really need active treatment, how do we ensure that they get their treatment despite the fact that pandemic is all over the world? And of course, in our own center, we have modified ESMO categories. We've added the 3rd one, which is people who really need screening. There are people that need screening. And if they don't get the screening, they are likely to develop malignancy. So they also have to be attended. So how do we ensure that these 3 categories are well attended to without any problem? So next slide, please. So what is necessary now is adjustment. Everything has to be adjusted. The way we interact with the patient, the care we give, the dose we give, the type of treatment we give, and the visitation, they have the clinic visits, everything has to be adjusted to ensure that we are able to accommodate everyone as we should. So we ensure that there's less physical contact with the patient, and then there's teleconsultation. For example, we have a platform called ONCOLOGY. ONCOLOGY is a well-established platform in which oncologists can attend to patients or people that need oncology care via an online platform. And that is one of them is very good. Then we reduce clinic visitation. Then there are patients that have been on intravenous drugs, and because for us to administer intravenous drugs, they need to come to the hospital. And some of these intravenous drugs have oral form or tablet form. So if we after the assessment, we see that the patient can benefit from the tablet or the oral form of the drug, which will not make them to come down to the hospital. So we change it as long as it doesn't affect their survivor and it doesn't lead to disease progression. And the same thing applies to the doses that we give patients. For example, there are patients that come to the hospital probably to receive their chemotherapy, immunotherapy, or whatever treatment they are taking every 2 weeks or every week. So we find a way to increase the interval probably to 3 weekly or to 4 weekly, as long as it will not affect their survival and it will not lead to disease progression. Because this is essential. While we are trying to take care of the patient, while we are trying to, ensure that patient doesn't have COVID infection and at the same time doesn't give the oncology team members COVID infection, we at the same time must ensure that patients don't have disease progression and they are able to get their care. They are able to get their care in order to have the best or the optimal survivor that they will. Next slide, please. So what do we do again? We ensure that our patients come to the hospital when they need to, and it is based on appointment. Patients are called, they call before they come in. Nobody walks into the hospital like that anymore, except it is emergency. And when we have a protocol, like in my center, we have a protocol to handle emergency. We have a protocol to ensure that all our patients are well taken care of. They come in on appointment basis, and when they come, they call ahead. So the oncology team is expecting them, and then their treatment is prepared. And some of them also have to do their investigations before coming. They don't come to the hospital and we are sending them out again for investigation. Because if we don't ensure that we reduce clinic or they do investigation before coming, that means they're going to be having increased number of visits, clinic visits that they have before they receive their treatment. Then preventive measures must be followed. That's what we do here. Before they come in, they are screened. Everyone is screened. Everyone, the temperature is checked. Everyone feels the chart. We find out that everyone washes his or her hands with soap and water, and the other preventive measures are put in place. And even when they come in, they don't just walk into the hospital directly. They have to be in a particular location first. Then they are assessed by the team before they are allowed to come in. Then we screen everyone entering the hospital. Then we avoid crowds. We ensure that patients that can walk into the hospital without the assistance of any caregiver, they should do so, because we want to avoid people accompanying them, family members accompanying them. Those days that, many family members will come with patients, they want to know what's happening, the treatment they're giving, those days are over. Or when you want to admit a patient, you have about 5 people following the patient, trying to help in one way or the other. Those days are over. We ensure that the patient that can take care of himself or herself walks in without other people coming in, or patient that cannot take care of himself or herself as maybe just one person trying to assist. And as much as possible, we avoid crowds at all costs. Next slide, please. So we avoid or postpone some treatment that may result in immunosuppression. For example, if a patient will not need chemotherapy, we don't give chemotherapy. If a patient will not need a type of immunotherapy that can lead to immunosuppression, we don't give it. Otherwise, we are going to be causing more damage or more problems for the patient. So, for example, a patient is on follow-up care, does not need chemotherapy, does not need immunotherapy. We don't just say, okay, come in, let's give maintenance. That is not necessary. So, as much as possible, patients receive their care that is important, that will add and benefit them in terms of survival. If it will not add to the overall survival, then we don't add it. Then patients on medical tourism, we have patients that come into our center from other countries to receive cancer care. So because of that, we ensure that they are isolated. We also ensure that they do COVID testing as much as possible. And for every case that we see, even in known patients that is suspicious, they do COVID testing before they are allowed to come in. Then other adjustments are according to the protocols. Different centers have different protocols all over Nigeria, all over Africa. So we also have our protocols. For example, we are already working on our protocol, trying to publish it, and then it's actually in for a peer review already. So as much as possible, we want people to learn from the protocol that we have adopted. We have had cases. It's interesting to know that the first case that was recorded, the index case in Nigeria, was not a patient with malignancy or with cancer. However, the first person that died of COVID-19 in Nigeria was a case of malignancy, or a malignant patient that had multiple myeloma and came from outside Nigeria, traveled outside Nigeria to receive treatment, receive chemotherapy, but on getting back, got infected with COVID-19, and that was the first mortality that was recorded in Nigeria. So that means oncology patients are peculiar, and they must be protected and they must be cared for accordingly, despite the pandemic of COVID-19. So different centers have different protocols to to follow. And we have some interesting, cases here that we are also trying to write up for publication. For example, we have a patient who received treatment. It's a case of advanced colorectal cancer. Received treatment with Capox and Avastin, that's bevacizumab, and then developed severe epistaxis from bevacizumab. We tried to stop it. Eventually, we had to put nasal tamponade, but that couldn't even stop the bleeding. So we tried as much as possible to get the involvement of ENT surgeon. And when the ENT surgeon came in, they have to do chest CT scan. At the end of the day, the features they saw, because the patient apparently had secondaries to the chest, metastasis to the lung. So the features they saw on the chest CT scan, really baffled them and made them to start suspecting COVID-19. So they had to send the patient back and, requested for COVID-19 before they could continue. Eventually, the patient came out to be negative. We tried to convince them that the patient doesn't have COVID-19, but they wouldn't, accept that. But that does not change the fact that patient treatment has been, delayed because of the fear of COVID-19. So in many ways, COVID-19 has affected the care that we give to patients, and many of them have experienced, delay in one form or the other. Next slide, please. So cases and deaths. Now, what's going to be like tomorrow? Like someone said, that COVID-19 has come to stay with us. It's in the neighborhood, and we don't know when it's likely to go. So as much as possible, we have to adjust our lives to, to suit COVID-19 era in such a way that we continue our life, we don't put our life on pause, we continue to care for the patient, we continue to ensure that everything goes on very well. So the cases, number of cases and deaths, still increasing, and then it looks like COVID-19 has come to stay, like I said. The new symptoms and complications are being, are being recorded every day. There was a time that they just said, okay, respiratory symptoms, all of a sudden, gastrointestinal symptoms came, all of a sudden. So we are now having different symptoms that come with COVID-19, and with that, we will need to continue to adjust even our protocols, the way we care for patients, as much as possible in oncology. Please, next slide. Then there will be more adjustments to make, and of course, every oncology member needs to, as much as possible to be up to date in this, and then active research on COVID-19 should continue. Next slide, please. So thank you very much for that, for your attention. So I'll be glad to take questions if we have any questions.
Thank you, Dr. Adeniji, and a great presentation. We've talked a lot about the infectious diseases and a bit of the non-communicable in terms of the cardiovascular. So you've brought in a fresh perspective on oncology. And yes, it would be great if there are any questions. One question I had is, I think it's what COVID is really teaching us is really the need for, early detection and understanding how do we deliver healthcare remotely, having point of care diagnostics. How are you coping, and how are you seeing potentially delayed diagnosis of cancers, and if so, what would be the strategy for addressing that?
Okay, thank you very much for the question, Robert. What we've been able to adopt here, because it's essential that we make the diagnosis even before we proceed with the care. And when patients come into oncology facility directly, some of them will need to have diagnosis, and because of that, we need to be going back and forth, and that may take more time and also give more contact with the oncology team. So what we'll have adopted here, as much as possible, there are some investigations that we encourage patients to go to the affiliated centers affiliated to our cancer care to do before coming. So when they go there, the centers observe all the preventive measures, and then they do the investigations. Then when they do the investigations, they don't just bring them to the hospital. They send them to us via emails, and then we are able to discuss some of them on via tele platform, like a consultation to review the results. And then after reviewing of the results, we tell them the stage, we tell them what is expected. And when they need to come in for treatment, that's when they come into the hospital. So that helps a lot in reducing the number of time they come to the hospital. They do get that. So we review the results, they do it before they come, and then they come in for the treatment. And they come in for the treatment based on appointment. And that has really helped a lot in my center. Thank you very much.
Thank you so much. If there are no other questions, I want us to go to the last, but we always say not the least. In fact, probably one of the highlights that I've been waiting for also, Dr. Nicola Bullet, who is also an associate professor at the University of Connecticut in the US. She, however, bills herself as a public health anthropologist and independent consultant. This is because, like Siwo, she's also on loan to the United States. She's originally from South Africa. And Dr. Bullet is a public health anthropologist who has worked in the global health space, focusing on how can you deliver effective, cultural centered, and structurally responsive policy and practice. I think COVID-19 has taught us there's a lot to speak to this disease beyond just the biology, but also the other social determinants of health. So Dr. Bullet uses the tools and skills of an anthropologist to interrogate factors contributing to disease and healthcare needs. And offering she offers multi-level perspectives on public health programming, service delivery, and policy. Her specific fields of interest include HIV, infectious diseases, disease prevention technologies, health communication, and community collaboration. She'll be sharing with us how all of this comes into COVID-19. As you've seen from the slide, she's already invented a whole new science called syndemics. And so I will invite you, Dr. Bullet, to kindly share with us a little bit more about syndemics and how can this help us to address the COVID-19 pandemic?
Thank you, Robert, for that kind introduction. Also, like you've all said, thank you to the organizers of this panel. It's been really fascinating to hear these different viewpoints and perspectives that I hadn't considered. So really great to get these insights from the ground and from your different world views. I'm presenting on something different. I can't claim to have made up this perspective. I'll go up into the history of this in a moment. But yes, looking at it in a slightly different way. Looking at these comorbidities, but also how they play out in different social contexts, and recognizing that the comorbidities, although biological, and we've heard about the biological interactions of some diseases, but also recognizing the vital importance of social dynamics in those comorbidities and the interplay of those social arrangements. Next slide, please, Nick. So first, we must recognize we are in a global crisis. This is a shared pandemic. But as many of you have mentioned, the way the pandemic is exposing itself in different places is quite unique. So we have unique epidemics in lots of different spaces. And we need to understand those unique arrangements in order for us to present some unique opportunities to engage with this epidemic as it exists in our spaces. So it is presenting quite uniquely here in Massachusetts than it is even in New York City, which is not that far away, than it is in South Africa, which is very far away. Next slide. So syndemic offers us an opportunity to look at those uniquenesses and those arrangements of both biologies and social contexts to be able to develop some informed responses. So syndemic as a concept was developed by a medical anthropologist, Merle Singer, in the mid-1990s. He was examining people living with HIV here in the northeast of the United States and noticed a clustering of health conditions within that population. Specifically, he was noticing substance abuse disorders and violence along with HIV. And the more he examined these, the more he recognizes they weren't just co-occurring conditions, but they were actually interacting on a biological level, and that these interactions were being exacerbated by certain social conditions that allowed them to cluster more in some communities than in other communities. And so we came up with this idea of syndemics to add on to existing concepts like the social determinants of health or comorbidities, to recognize that you really have an interaction of things going on, and that this interaction of things is actually synergistic. I see that I have a typo in the slide, but the synergistic response actually exacerbating the outcome of conditions. So rather than just this condition and this condition adding on, but actually making it even worse than beyond that simple summation. So quite complicated and incredibly difficult to prove. Next slide, please. So that syndemic, two components of the syndemic that are important here. So first is the interaction of the biological and the social elements. So we're not just talking about biological comorbidities, the best example being here of HIV and TB, which we've already discussed. We know that these two conditions exacerbate one another and vice versa. So HIV making TB worse, TB making HIV worse, that is well understood. But not all communities suffer from both conditions. And why is that? And that's because of the social context. So like, for example, here in the Northeast, we don't see HIV and TB coexisting. Whereas in South Africa, among mine workers, we see that it is a huge burden. Among Russian prisoners, we see that HIV and TB are huge burdens. And that, we argue, is because of the social conditions that allow those two biological conditions to coexist. So for mine workers in South Africa, the working conditions being that they're in close confined environments, both in the workspace and in the living space, poor access to medical treatments. Obviously, this has improved of late, and other social arrangements that allow these two conditions to coexist and cluster. The other aspect of the syndemic is that it is synergistic. So as I mentioned, that these are actually interacting together to make each other worse. From a public health standpoint, if we can prove the synergy rather than just the additive response or a causality chain, we can actually then just influence one aspect of that dynamic, and it should have a positive impact on all the other dynamics. So rather than a multi-pronged approach, that means that we have to address HIV and TB and social conditions, we could perhaps just influence one of those elements, and we could see a positive effect on the rest. And I think you might argue that because of the positive influence that South Africa has made in terms of its very big HIV epidemic, we are seeing a positive response in the front of TB and also in income levels, although to some extent South Africa has tried to address all three simultaneously. So keeping that in mind, next slide, please. Thinking of the COVID-19 syndemic, and as I mentioned, these are really, really hard to prove syndemic arrangements. So this is just theoretically what we're seeing that could be interacting elements. So we've talked about these already: HIV, tuberculosis, diabetes, heart disease, and a number of others. And I'm going to lay on a social dynamic of poverty. As I mentioned, these are going to be uniquely arranged in different spaces, depending on local politics, local health histories, local socioeconomic environments. So we need to understand these in different spaces and in different times. Next slide, please. So let's start with HIV. So very limited data has been published to date. What has been published is a study out of Spain. The sample size was quite small, and among the HIV positive patients, their virology was suppressed. So these were patients that were actually doing very well with their HIV condition. Unfortunately, this is not representative of most of sub-Saharan Africa, where we have still a huge number of HIV, people living with HIV who do not have access to antiretroviral drugs and are not virologically suppressed. So we may not have the same positive experience as Spain, where it didn't seem that the HIV was having any effect on COVID-19 or vice versa. Another troubling dynamic with HIV is, as mentioned already, access to those drugs may actually become more limited given closures in borders, closures in factories that are going to increase the costs and also delay distribution. Next slide, please. When it comes to TB, we've already mentioned the interaction between HIV and TB. A study out of China indicated that with both active and latent TB, it increases susceptibility to COVID and COVID morbidity and mortality. So we are concerned about this dynamic, even though we don't have a large amount of data here. We have had success of treating HIV and TB in South Africa, as I mentioned, but we need to make sure that we maintain access to those drugs as well as screening practices. Next slide, please. Turning now to diabetes and heart disease, as mentioned by the other speakers, these comorbidities are quite concerning, and this is a very global concern, even though perhaps the data is not presenting yet in South Africa. But what we find is that the existence of diabetes and heart disease can exacerbate COVID outcomes, but similarly, COVID can actually make the diabetes and heart disease worse and can actually even cause the onset of diabetes where there previously wasn't any. So as I mentioned, this is an increasing concern in South Africa, but also globally, we're seeing that individuals with these conditions have significantly worse outcomes with COVID. Next slide, please. So finally, poverty. So poverty is this big concept. We understand that people in poverty conditions, low resource, low incomes, are going to be more exposed to COVID-19 because they're living in households with more people. So social distancing becomes very difficult within the household. Social distancing becomes very difficult outside the household as people who are in low resource areas and communities have to continue to work. So they're being exposed at the workspace. They also may be working in areas where their employers are not taking necessary precautions. They're having to continue to take public transport, which further exposes them to COVID. They may also have existing health conditions or limited access to water and hygiene facilities to make sure that they maintain high hygiene standards. I have some facts there about South Africa's poverty conditions and extreme inequality that really makes it a concerning situation, particularly in that country. Next slide, please. So when it comes to South Africa, and I'll look at this, so I'm specifically offering a South African perspective here, the extreme national lockdown was obviously warranted because we have high rates of HIV, high rates of TB, increasing rates of diabetes and heart disease. And so they went to the extreme measures of closing national borders, limiting local travel, closing down all non-essential businesses and schools. This obviously had a significant impact on individual and national economies. So individuals who were already highly exposed to COVID were even more affected, given loss of jobs, loss of incomes, loss of access to health services. Obviously, the South African lockdown has been limited, so increasingly businesses are opening, public transport is starting up again, and efforts are being made to ensure that people are safe, wearing masks, having limited exposures, and consequently we're seeing the numbers rising, particularly in low resource communities like the townships outside of Cape Town, Johannesburg, Pretoria. There are reports of hospitals being overburdened. It's hard to know whether this is just some extreme cases or a general experience nationwide. Last slide, please. So turning back to syndemics as a perspective and the advantages that syndemics offers us at this moment is that first it highlights that social conditions are an essential dimension of the disease cluster arrangement, and we cannot forget about them as they're really going to not necessarily drive the epidemic, but create the epidemic environment that allows different conditions to coexist. And secondly, the syndemic perspective informs public health responses. If we do truly have synergistic arrangements, we could potentially start to just isolate and address certain elements of the arrangement rather than trying to address everything simultaneously. And in low resource settings, this is particularly important. For South Africa, it is imperative to maintain high access to antiretrovirals, to maintain TB services, both in screening and in treatment. Because if we can do this, we could potentially start to at least limit the negative consequences of COVID, although likely we're going to see significant impacts of COVID regardless. And I'll leave it there. Thank you very much.
Thank you very much, Dr. Bullet. And this has been a really interesting presentation, very fresh perspective, not just focusing on the biology, but understanding the context around it. Sorry, I just realized my video was off. Yes, and I think we are at a good point where we can be able to open up the discussion to everybody and taking a few questions. And one of the key messages that I think has been coming out throughout is, yes, COVID is here with us, but we should also really be careful not to just be overwhelmed looking at it and forget these other comorbidities that are equally important. And some of the suggestions and the strategies that you've been bringing up, not just you, Dr. Bullet, but even the other presenters, I think are things that we do need to look at keenly as a continent. And I'm also glad, even from the drugs development perspective, oh boy, there's a lot of construction going on, that there's also some hope. There's good reason to look forward to new therapeutics coming forward that can also be able to address the COVID-19 situation. I'll open up the floor to questions from our participants. Anybody who has any quick questions?
Hello.
Hello.
I am Dr. Iman Alam from Egypt. I wanted to add something. Maybe you will discuss it in another event. The role of antioxidant agents and antioxidant medicinal plants is very important in this issue. Already I have some lectures in this regard. This is my area of science, and antibacterial and antioxidant agents. I think it is very important to focus on antioxidant agents. And finally, I wanted to thank all of you regarding valuable lectures. And thanks for encouraging yourself to continue. Thank you very much. However, there is a mistake. I know that it is not by you, but don't worry. We are completing with you, and we are still interested with you. A valuable lecture. I wanted to focus on Jeffrey because of his volunteering work to continue, however, what has happened. And I wanted to thank all of you for being till the end, and thank you for all organizers. Thank you very much.
Thank you, Dr. Alam.
Thank you.
Very kind.
Yeah, thank you, Dr. Iman.
Thank you.
Thank you.
Thank you very much.
And Nicola, if I may, I think there was also a question, I had a question about, I think you mentioned that you noticed that COVID can increase the risk of diabetes even in patients that didn't previously have diabetes. I didn't quite catch if there was any more detail about the mechanism of action behind that, or if we understood that yet.
So, you know me, I'm not that kind of scientist. There was a very interesting Lancet piece that sort of detailed the diabetes connection with COVID, which seems to be better understood than some of the other connections. So there was a lot more literature about diabetes, right. And that reference is there. So you can maybe dig into those details of the actual biological mechanisms of that.
Is there a socio-economic link? Is probably more what I meant. Like, is there something to do with the societal impact of COVID?
With the diabetes. So obviously in different situations, it's going to be different. So individuals in South Africa who have diabetes, it's varied. And perhaps Dr. Moya can help me with this. It is a combination of both wealth and actual poverty. So we have sort of two different dimensions with diabetes. And I think you can see that it also play out here in the US. So you have malnutrition on both fronts, the obesity and sort of the lack of good nutritious value, which is contributing to mostly what we see as type 2 diabetes in South African continent. So here, the poverty conditions of the diabetes, it would be the sort of poverty as the social underlying factor. that's preventing access to good quality food and a reliance on heavy carbohydrates, contributing to the onset of diabetes. And then the biological mechanisms taking over, the delayed access to treatment and care for the diabetes, and then other certain comorbidities that exist with diabetes itself.
Great, thank you.
Okay.
And I guess these things are exacerbated by COVID because they have restricted access to care, and maybe also dietary demands aren't met by increase in probably lack of being able to work because of lockdown restrictions. That's really interesting.
Mm-hmm. And increased exposure in the home environment as well.
Mm-hmm. Great, thank you.
And maybe just to add here quickly, thank you, Dr. Nicole. That was very informative, and as one more on the biological side, I think it's your perspective is very crucial, because this is one reason why many biological studies sometimes fail to pick up important disease associations. So, for instance, in genetics, when they do these gene association studies to find a genetic variant that might enhance susceptibility to diabetes, it's normally difficult to find variants that are there across populations. And I think some of the reasons goes to how the studies are designed, and they don't take into context the social factors that you've raised. I think that's very important. And on the diabetes, just to mention also is that, you know, many of these chronic conditions, including diabetes, normally have an immunological component. And this is a little bit, it's not the way people have thought about diabetes for a long time, because people think of diabetes and they think of insulin. But of course, there's very good evidence that many of the manifestations of diabetes has to do with a dysfunctional immune response, and which could link it to something like COVID, and also make it a comorbidity in other conditions. So thank you.
Thank you. Very interesting.
Thank you. So we are running way over time, understandably, and so we want to bring it to a close. And I want to kindly request, if you do have any questions, please feel free to share them, and we'll be able to, of course, get some more feedback and some of the answers from the panelists. And before we wrap up, I think I'd like to give each of them a chance to just give a quick final remark, just to kind of bring your message home, and then be able to call it a day after that. I'd like to probably ask Dr. Adeniji. I know you are running a bit late for another engagement. If you could go first, and then we can have everybody else. I'll continue to call you out.
Okay, thank you very much, Robert, for that. And once again, I want to appreciate the organizer of this lovely event. I also want to appreciate everyone who has taken our time to participate. I'm sure one way or the other, you would have picked, you know, something that you will benefit from. And don't forget that when we talk about COVID-19, a lot of things have changed. And then comorbidities are on the top of the list. And oncology care cannot be left out, because we need to do active research, and then we also need to take care of our patients, despite the fact that there's pandemic all over the world. So please, when you see a patient or people with cancer, as much as possible, and you are maybe part of the oncology team, try as much as possible to put up the measures, the preventive measures, and at the same time, still give them your best care. Our patient needs our attention. And on this note, I want to say thank you once again for participating, everyone. And thank you for having me, Bobab. And thank you, the organizers, Robert, Nick, Nicole. I'm so glad to be here. Thank you.
Thank you very much, Dr. Adeniji. Dr. Goha, any last words? I think you may have left.
Oh, he's with us, I think. Dr. Goha.
Dr. Goha.
Yeah, yes.
There you are.
I wish to thank you all for this event. It was a very interesting webinar. And the take-home message is COVID-19 pandemic is still there, and we are still learning from how to deal with it. The only thing that is valuable in this era is to keep distance. Social distancing is very important, and wearing a mask and washing hands. These are the most three important things in preventing the spread of the disease. And as physicians and as a cardiologist, where special attention should be taken for cardiac patients, not for delaying management of these patients because of the COVID-19, by adapting to the guidelines. Taking the measures that is necessarily needed without like delaying management of these patients. Thank you for this events, and see you soon.
Thank you so much, Dr. Goha. Dr. Moyo, you can share just a few quick final remarks.
Okay, thank you for the opportunity. I think it's been a very effective. I just appreciated Nicola's presentation, because our institution really is based. So I am a clinician who crossed over to the other side, because I think for me, the penny dropped. That is not only about biological factors, but it's about where people live, how they live, and how they experience disease. And I think COVID-19 is one of those conditions that really shows us that it's not only about the vaccine, it's not only about the drugs, it's about looking at it from a holistic approach. So I think that we just need to take that holistic approach. And from what Dr. Sorry, I forgot his name, the oncologist, I think that protocols that integrate care are very important. For us in the TB world, organizations WHO, like the International AIDS Society, they've created these protocols that help us have a comprehensive view. One of the things that struck me about the case that he presented of a patient with epistaxis, and the colleagues, it was almost like a back and forth between the colleagues. So I think building protocols where there's integrated key is really important for us to really serve our patients. And my final point is that on diabetes, I think that in countries like South Africa, we know that some of the antiretroviral drugs, the side effects is risk for diabetes, for example. And also we know there's a link between TB and diabetes. So these are the things that our epidemic is playing into. So we don't know whether that diabetes, is it only maturity onset? Is it linked to TB? Is it linked to HIV? And those are the things that we need to think about in our context, because even when we treat our patients with all the drugs, that are in our treatment guidelines, how does that play out in terms of creating other conditions that may be comorbid conditions with COVID-19, for example? So on that note, thank you very much.
Thank you so much, Dr. Moyo. Dr. Siwo, are you still with us? Can you share a few final remarks?
I think Jeffrey had to run off to another meeting, so we'll forgive him since his presentation was interrupted so rudely before.
All right. Dr. Bouled?
Yeah, so I will offer like a different perspective. One of the things that I've noticed is that we're so eager to find solutions and resolutions to this that we're quick to jump at any sort of new data that is presented to us. So I would ask that we all remain very critical and cautious of all the data that is presented to us, even in our high-tier journals like The Lancet, which have had to retract certain publications because they were not well vetted and well proven. So I had wanted to discuss with Dr. Moya some of the comments she made about stigma, and Robert, your comment about sort of low rates of mortality in Africa. And I do wonder how much we should be cautious as we look at this data. Perhaps we have underreporting for various reasons. So cautiously moving forward in the world of the unknown COVID.
Thank you so much. And I think that's a great note to end on. Mine is just to say thank you very much to everybody for taking the time, for your contributions, for sharing your thoughts, and especially the amazing work that each of our panelists is doing. I think there is cause for cautious optimism, and I think there is also a lot more to discuss, especially jumping on, piggybacking on Dr. Bullett's last remarks about the whole social determinants of health and how these endemics can actually be used to help us understand and get a better understanding of what's happening on the continent. It could be we are underreporting. It could be our population is just, all over the place, not so urbanized. And so the spread is not as fast. And so there are so many other things that could be happening, but it really takes research, takes science, credible science that can withstand scrutiny to be able to answer all of these questions. I'd like to just highlight that this is again is the first of 3 webinars, and I want to make sure that you're all aware of the next webinar, which will be happening on the 29th of July. Again, similar time, and again we are hoping that you'll be able to join us and continue to contribute to this conversation as we understand what's happening in terms of COVID-19 in Africa. Should we be optimistic? Should we not? I think there's clearly a lot that's happening. And for me, I'm just super encouraged that we are not passive, but we're really contributing to the vast body of knowledge that's coming up. And I think I also believe we will also be able to contribute in terms of learnings. So with that, I'll thank everybody and invite you to look forward to seeing you on the 29th. Thank you and have a good day.
Thank you, everyone.